Well, hello, everyone. Welcome. I do want to invite everyone to make sure they get a boxed lunch and something to drink. They are separate, so you're going to have to go to both sides. I was just telling someone that in my meetings that I have with people, my name's Claire Sheehan, and I'm the president and CEO of the Alliance for Health Policy. And I go around and I often hear people's stories about what the Alliance means to them. And I can't tell you how many people say to me, "You fed me during my 20s. I didn't have 2 pennies to rub together, and I could always count on a boxed lunch at an Alliance briefing." So we embrace that heritage as fulfilling not just your needs for intellectual sustenance, but also lunch, and continuing that proud tradition today. So certainly help yourself. The Alliance is an organization that's been around for more than 30 years, and I'd love to know if people feel comfortable, how many people here have been to an Alliance briefing before? All right, so we've got some of our traditionalists with us, people who know our history. That's wonderful. For those of you who are new to the organization, what we're most known for is the 30 years that we have spent educating both staffers, but the broader health policy community as well, about complex topics related to healthcare policy. So we were founded more than 30 years ago by Senators Rockefeller and Danforth. The idea was that healthcare policy was very complex. I don't think it's gotten easier since then. When I came into leadership of this organization almost 2 years ago now, one of the things I noticed is that in addition to our educational work and the importance of doing that educational work, what we had really fostered over 30 years was an incredible community. And that community is rife with people who are experts in their own right, people who have deepened and broadened their knowledge on health policy. And it's such an incredible asset to the organization that we went ahead and said, you know what, we need to build our programming around this. This is something that is so unique that it has to be the heart of our programming going forward. So when we think about our program life cycle, we now think about it in 2 stages, not just the educate, but we start with the incubate. So many of you in this room have had the chance to participate in the first stage of our programming, where we invite people with expertise, knowledge, and different perspectives on a topic to come together, share their insights and what they think is most important in the policy conversation today, and also co-create what we think the most important learning goals are. So when we come to the Hill with a program like this, you now know that it has benefited from conversations with people throughout the aging policy landscape, people who have different perspectives, people who are touching different parts of the proverbial elephant. So we are, by history, nonpartisan. We are, in practice, both nonpartisan and stakeholder neutral. And that comes through in this process. So what does that mean in practice? So today, this event is actually the culmination of what we call our signature series. We have been working on the topic of aging in America since January, and actually a little bit before. And we have multiple events and publications through that process. We start with listening. We released in February our insights report on what we heard when we spoke with experts about aging and health policy in 2025. And then we gather people together and have interactive sessions where we decide what we think are the priorities when it comes to education. Then we turn and pivot into that educational programming. I want to share with you, this is the webinar we did. We asked our experts, what were the core policies for aging? And then we put together a webinar specifically on each of those core policies. What are the top 5 things to know? If aging is an area of interest to you and you haven't taken advantage of this webinar, it is on our website and on our YouTube channel, and I encourage you to do so. We then came together and had our summit. And again, if you missed it, you can see some of our talent is actually in the room today. So hi to everybody who was on a panel. I see you all as you came in. But we had a wonderful experience throughout that day. And again, the content from that did not come from my staff. It did not come from my great ideas. It did not come from our board. It actually came from the broader community. And we had conversations about, what is missing in the conversation about aging policy today. And we went ahead and built our panels around those things. So ta-da, today, in addition to hosting this briefing, we're also releasing this series report. So I'm guessing that many of you in this room are engaged in trying to help educate people about topics on aging and aging policy. And we're releasing all of the recommendations that our community came together and decided on in our workshops. So that's in the report, as well as a list of some of these resources I've talked about today, QR codes for the webinar, and the summit topics as well. So you've also got a hard copy, because who doesn't love a hard copy at your table? So one thing I did want to share with folks is, in addition to adding sort of a structured incubate phase to our programming, we've also changed a little bit the way that we do our work. If you've been paying attention to the Alliance over 30 years, you know that we had a reputation for sort of being present week on week or month on month on topics of import on health policy, often in rooms like this. And, it was sort of come along, y'all come, was sort of the philosophy. This year we've started something new, which is we've started from the people. We've started from a class of 30 fellows with whom we've been working for about 7 months now, and we are actually getting towards the end of our first ever Congressional staff fellowship class. I think several of them, registered for this event, and I see some people in the audience. And we've had a really successful program in terms of being able to connect not just on topics of interest in health policy, but also do some skill building and some practical skills as well, and some leadership development as well. One thing I say when we talk about the fellowship is there's not a great huge HR department on Capitol Hill, and so we try to take on some of that work to help people see themselves as leaders in health policy and help reach their own goals. So I say that because we're hopeful to continue that work. And if anyone is sitting in this briefing and is interested in being in the next generation of our fellows, keep your eyes and ears open. We hope to have announcements in the coming months. So when I think about the Alliance and what we bring aside from the box lunches, I hear from people a lot about the value that this organization has brought to them or brings to them. Given that, I would challenge each of you today to take away a couple of things. One is, discovering a new idea. What is a different way of thinking about something? What is a concept you haven't heard of? That's something you should aim to walk away with. Secondly, experts and resources. We work with the best. You're going to hear from some brilliant leaders today in health policy, particularly in long-term care and financing. And look up their work. They have great resources on their web pages. Follow them on LinkedIn. Look to see what's coming out from these experts. And then finally, join our community. So if you do not follow us on LinkedIn, we are very active on LinkedIn, and you can always keep track of what we're doing there. I would encourage that. And you can also go to our website and sign up for email updates, including one specific to aging policy. So those are the three things I would think about in your seat. So although the Alliance has been around for 30 years, it is far from a foregone conclusion that it'll be here for years to come. And we are not a utility. We are not, an organization that has, dedicated funds coming from the taxpayers. So we are really here because these organizations and the people within them have invested and committed to nonpartisan and stakeholder neutral education on the topic of aging policy. So we are very grateful to them for that commitment. So we are going to take a minute now. I think I talked a little bit about our insights report and the aging work that we had done early on. We really do believe that listening first is important. And one of the themes that came across when we listened to many, many experts who have dedicated their lives to issues in aging policy was that there's an ongoing challenge where while aging is something that, if we are all lucky, will happen to us, there's often a disconnect, and we don't see ourselves as people who are going to be affected in aging. And so we did an exercise in one of our workshops that we're going to repeat with all of you. And so if you look at your table, everyone should have one of these cards. So it is interactive. We are working together here. And we're going to start with the idea that it's your birthday today, okay? So picture with me, you are sitting at your 80th birthday. What does that look like? This is an opportunity for you to think about what you want your aging future to be individually, personally, and then we'll turn to talk about it as a policy issue. So when you think about yourself at 80, we want to think about what is your ideal day in the life, right? What do you want that to look like? When you see yourself, what do you want that to look like? So here's a few questions that are included on your card. We can walk through them, but these are kind of the who, what, when, where, why, and how, right? So we can start with who's coming, who's in your life daily? Who do you see? Who's coming to your birthday party? Who's flying in? Who's somebody who you see on a monthly basis that might show up? What does your community look like when you're 80 years old? Next, what is exciting? What's a challenge? What are you looking forward to? Not just today at your party, but in that next week. What do you see yourself planning for? What do you see yourself motivated by? After that, we're going to think a little bit about what your routine looks like when you wake up in the morning. Where are you? What are you thinking? How does your day go? What activities might be on your agenda for the day? After that, we think about geography. Where are you? What does your living situation look like? How might your surroundings impact you? And then finally, we have a minute or two to reflect on what choices might have enabled you to experience this. And that's kind of the why. A lot of content on this topic of choices early for what we want our aging future to look like in our summit as well. So we're going to give you a minute. I'm going to put a little bit of music on. We'll see how this works. And we're going to give you a minute to think that through. Just, I think, 90 seconds to think that through. All right, wonderful. So I hope when you think about that exercise, you think about how you are part of the aging future, right? We are all, again, if we are fortunate, going to be part of the aging future. And with that, we're going to talk a little bit more about some logistics for today's program, and then we're going to get into the content. So you have another card on your table. It is this one. Does everybody see their green cards? Wonderful. Green cards, right? So there's a pile. So I would encourage people to grab a few. So the way that we're going to do questions, as I mentioned, we are very dedicated to listening, and we want to make sure that you have a chance not just to think of the question right when we ask you what the question is, but throughout the program. So you can write your question down, and then we'll let you know. We'll come around and collect them. So feel free to be writing down your questions throughout the program. And everybody has question cards, right? Nobody's without? Fantastic. Okay, great. So with that, it is my pleasure. I get to do the Mike Park introduction. So Mike Park is agreed to be our moderator today. Mike is a partner at Alton & Bird's Healthcare Legislative and Public Policy Group, and he also brings a wealth of government experience. So many of you might know him from his time as Health Policy Counsel to Senator Grassley as chairman of the Senate Finance Committee, where he helped develop legislation on Medicare, health IT, and program integrity. But he also spent time at HHS, both in as a project officer and managed Medicare payment demonstration projects for CMS, and in the Office of the Secretary at HHS. So lots of rich experience on the government side. So Mike is also, and this isn't that common, I don't think, both an attorney and an MPH. And I would say two things that are most relevant for this briefing is that I said we do a lot of listening and we do our interviewing of our experts. One of the things we ask is who is a trusted expert and someone who would make a great speaker. In addition to all of our speakers' names coming up, Mike's name came up not a few times. So we're very excited to have him join us as a moderator. He is seen as a real thought partner on issues of aging policy. And his most important credential in my mind is that he's the vice chair of a small but very important nonprofit organization called the Alliance for Health Policy. So Mike, thank you so much for agreeing to moderate today. And Kirsten, I'm going to give you that.
Thanks for the introduction, Claire, and thank you all for attending. We really have a fantastic group of panelists who can share their expertise on LTSS. I'm going to start with some intros, and then we're going to dive right in. So to my immediate left, we have Kirsten Colello with the Congressional Research Service, where she serves as a specialist in healthcare or health and aging policy. Her portfolio includes a wide range of health and social policy issues that affect the aging population, including home and community-based services authorized under the Older Americans Act and elder abuse prevention services authorized under the Elder Justice Act. Kirsten's work also includes eligibility, financing, and coverage of LTSS. She received her master's in public policy analysis from the University of Michigan and her bachelor's with concentrations in economics and sociology from Virginia Tech. Next, we have Allison Barkoff, who currently is the Harold and Jane Hirsch Associate Professor of Health Law and Policy and Hirsch Program Director at the George Washington University Milken Institute School of Public Health. For more than 25 years, she has focused on legal and policy advocacy to improve the lives of people who face the most significant challenges in accessing healthcare and other critical community services. Prior to joining George Washington, she led the Administration for Community Living within the Department of Health and Human Services from 2021 to 2024. Her roles were wide-ranging, including serving as the advisor to the HHS Secretary on Aging and Disability Policy. She oversaw national disability and aging programs and also led cross-agency initiatives related to LTSS, civil rights, housing, direct care workforce, family caregiving, healthy aging, and public health. Allison previously served as special counsel for Olmstead Enforcement at DOJ's Civil Rights Division and also held senior roles as an advisor both at CMS and the Department of Labor. She also held leadership roles at the Bazelon Center for Mental Health Law and Center for Public Representation. She has testified before Congress numerous times, as well as the U.S. Commission on Civil Rights, and is a nationally recognized expert on LTSS, disability and aging policy, Medicaid, and civil rights. To Allison's left, we have Ann Tumlinson, who's founder and CEO of ATI Advisory, a national healthcare research firm focused on improving how the U.S. finances and delivers LTSS. She has deep experience in Medicaid, Medicare, and caregiving policy. Ann advises states and federal leaders on strategies to meet the growing LTSS needs of older adults and people with disabilities. She previously served in the office of the late Congressman John Lewis and on the healthcare team at the White House Office of Management and Budget. And then last but not least, we have Robert Espinoza, who currently is a distinguished fellow and senior advisor at the National Academy of Social Insurance. Robert is a nationally recognized expert in workforce, aging, and caregiving policy. He At the National Academy of Social Insurance, he currently leads efforts to build support for sustainable long-term care financing that meets the needs of older adults, people with disabilities, and the care workforce. Previously, Robert was the CEO of National Skills Coalition, and before that, Executive Vice President of Policy at PHI, the nation's leading authority on the direct care workforce. His work has appeared in major outlets such as the New York Times, Forbes, and NPR, and he was named to the inaugural Care 100 list as one of the top country's top leaders reimagining caregiving in America. Finally, Robert also serves on the boards of the American Society on Aging and the Frameworks Institute, and he hosts A Question of Care, which is an award-winning podcast on the future of caregiving. So why don't we go ahead and get started? We're going to have Kirsten kick it off with some level setting, talking about the current structure of LTSS delivery and financing.
Good afternoon. Thank you to the Alliance for Health Policy for hosting this congressional briefing on LTSS. It's a really important topic that probably doesn't get the attention it should. So thank you for making this part of the signature series. In the time I have, I'm going to set the stage, if you will, and provide an overview of LTSS, why it's different than medical care, and what that means for public policy and the way we pay for LTSS in the United States. So what is LTSS? Well, it's both health and social services and other types of supports that are needed by people who have limitations in their ability to perform daily activities due to various conditions. What makes LTSS unlike other types of healthcare services or medical care in general is that it's not curative. That is, LTSS does not diagnose or treat disease or illness. There's no expectation that an individual will be cured or rehabilitated once they have an LTSS need. And once individuals have an LTSS need, they generally have that need for the remainder of their lives. So that means the types of LTSS an individual receives, whether it's personal care assistance or assistive devices or technology supports, really depends on the individual. It's a person-centered approach where the outcomes associated with providing good quality LTSS are based on the personal goals, the preferences, and the quality of life outcomes of each individual. So how is LTSS measured? How is it determined? Need for LTSS is based on functional limitations in the ability to perform certain daily activities, primarily in three ways. The first is activities of daily living, or ADLs, which are activities people need to be able to do to take care of themselves. The second is instrumental activities of daily living, or IADLs, which are activities that people need to be able to do to live independently. And finally, people may require supervision or assistance with accomplishing these ADLs or IDLs due to cognitive impairment. And so what does this mean for public policy? The level of LTSS need, that is whether individuals have limitations in 1, 2, 3, or more ADLs or IADLs, often forms the basis for eligibility in both public programs and private long-term care insurance. And there are two policy examples I provided here. The first is private long-term care insurance plans. It's probably important to say that LTSS is not covered by private health insurance and generally not covered by Medicare. So you have to purchase a separate long-term care insurance policy, typically decades before you need it. Most plans on the market today are tax qualified, meaning there are certain minimum standards and consumer protections that policies must meet for an individual to be able to receive a tax benefit. One of these minimum standards is that you're eligible to receive an LTSS benefit when you meet what is referred to as HIPAA level of care need. This is defined as 2 or more ADLs or supervision due to cognitive impairment. And these provisions were enacted under the HIPAA legislation and are part of the tax code today. A second example is under Medicaid, which typically requires an institutional level of care to receive Medicaid-covered LTSS. States define the level of care criteria under their Medicaid programs, so there's a lot of variation here, and states are often using a combination of ADLs, IADLs, and other criteria to determine LTSS eligibility. Another important point about LTSS is that it's different in many ways from other types of healthcare services in that it's provided where individuals also live. usually in private homes. But it's really important to think about the housing and the built environment and how accessible that environment is for individuals with LTSS needs. When we talk about where LTSS is provided, we typically distinguish between two types of settings: home and community-based settings and institutional settings. And this distinction is really important for Medicaid programs, as states are required to cover institutional care, such as nursing facility services, but home and community-based services are generally optional for states. And this results, again, in additional variation in what's covered across state Medicaid programs. So who needs LTSS? While we are focused on aging and LTSS today, the important takeaway here is that LTSS affects individuals of all ages and represents a very diverse population, those aging with disability and those aging into disability. In fact, if you live to age 65, and congratulations, all of you just celebrated your 80th birthday. But at age 65, it's estimated that more than half of Americans at some point will need LTSS. 12% will need care for less than a year, and 22% will need care for more than 5 years. To provide more context about the LTSS population in the United States, about 18 million adults have an LTSS need, and more than half are age 65 and older. Another data source focusing on older adults estimates that over 7 million adults 65 and older meet that HIPAA level of disability, which are 2 or more ADLs, or the need for supervision, and that's the trigger for that private long-term care insurance eligibility. Now, most individuals with LTSS needs live in the community, and just over 1 million live in nursing homes. So finally, this slide provides information about how we pay for LTSS in the United States. This figure shows payment to paid LTSS providers, such as nursing homes and home care agencies. Total spending on LTSS in 2023 was almost $564 billion. This is about 14% of all healthcare expenditures. Most of that spending was in public programs, with Medicaid being the largest public program and largest payer of LTSS. Almost 1/3 of spending was private spending, either out of pocket or through insurance. But the last point I want to make is for us to think about our entire long-term care system in the United States, not just the paid providers of LTSS, but those caregivers, typically family members and friends who provide uncompensated care. And estimates of the economic value of family caregiving are more than what we were spending on all paid care. So our LTSS system in the United States is primarily family members and friends providing care and supplemented by these public programs and private payments for LTSS. And so with that, I'll end my presentation here. I'll turn it to Allison, but obviously there's a lot more to dive into on these topics. Thank you.
Thank you, and good afternoon. I wanted to add my thank you to the Alliance for Health Policy for having this incredibly timely and important briefing. And looking across the room, I'm really heartened to see a lot of staff from congressional offices that I recognize, foundations, aging and disability organizations. And thank you for being here really for this important topic. I'm going to focus on the piece of the puzzle that Kirsten spoke about, focusing on being able to age in the community, and particularly talking about the programs that support home and community-based services that help people be able to age in their own communities. Let me just start with the fact that if you look at all of the recent AARP surveys, most older adults, and I bet if I asked people to raise hands in the vision that you had on your 80th birthday, you probably are thinking about being connected to your own communities, your own friends, your own families, and being able to live in your own home or some other community setting. We know that it's not just what most older adults want, but it can be cost effective. In general, 3 people can be served in the community for every one in a nursing home, and it can lead to better outcomes. And as Kirsten mentioned, there's a real misperception that the majority of older adults are in nursing homes, but actually it is a very, very small fraction, less than 5%. And so we really need to, as we think about aging and aging policy, we really need to think about expanding access to home and community-based services. I also want to emphasize a point that Kirsten mentioned, which is this real intersection across aging and disability. Older adults may not consider themselves or identify as people with disabilities, but if they are receiving or eligible for long-term services and supports, they actually are people with disabilities. And we have many people with lifelong disabilities aging into our aging system, and we have many people aging into disability. So we need to really think about, and again, I'm really pleased to see people across aging and disability in this room together. Okay, this slide should take your breath away. So for anyone who doesn't think that long-term services and supports is an issue that we need to move from the back burner to the front burner, look at this slide. We have 11,000 people turning 65 every single day. That's actually larger than a small town. I Googled what a small town was. It said that's 5,000 people. So every day we have people living longer, and we have people with disabilities living longer. The demographics alone, we will have more older adults than younger people under 18 in this country by the turn of this decade, and already more than a third of states have more older adults than children. So these demographics should really convince all of us in a bipartisan way that we have a lot of work to do to focus here. As Kirsten mentioned, I'm going to talk a little bit about Medicaid, which is the big game in town when we talk about home and community-based services. And when we look at surveys of older adults, or actually most Americans, people mistakenly believe that Medicare covers long-term care. It does not. And so it's really important that we think about both Medicaid, and as we talk and across this panel, also think about how we expand beyond Medicaid. It is an optional benefit. Most states offer it, but what that means is because states must offer nursing home and institutional care, and home and community-based services are optional, we have 700,000 people sitting on waiting lists in this country. And just to give some examples of the types of services that the older adults who are lucky enough to receive home and community-based services can access, it includes things like personal care services in their home, adult day programs, respite, transportation, and home modifications. I know we're not talking about housing, but people, the H in the HCBS is about a home, and we need to make sure people can age in place. We've seen a huge expansion over the last several decades of home and community-based services. And we often talk about states rebalancing their systems. You know, historically, Medicaid only covered institutional care. It wasn't until the 1980s that even home and community-based services were a program. And that has gone from being, you know, the sideshow to really being the centerpiece of long-term services and supports. And because of really important work by Congress to expand a number of different home and community-based authorities, like Money Follows the Person, the Balancing Incentive Program, enhanced funding through the American Rescue Plan, and even a new option for home and community-based services in H.R. 1, we've seen this transition from the 1980s, where it was 1% of funding went to home and community-based services, to now 65%. And another driver has been, I'm a longtime civil rights lawyer, and in disability rights laws, like the Americans with Disabilities Act, there is an integration mandate that requires public entities to provide supports and services to people in the most integrated setting. And a Supreme Court decision from 1999 called Olmstead versus LC, which has really been a driver for states expanding home and community-based services to people who can and want to live in their own communities. But Medicaid HCBS cannot be our only solution. Number one, we are relying on a poverty program that has strict income and asset limits. And for many older adults, it creates this situation where they are forced to spend down to access the care that they need. In addition, there is what we often call an institutional bias in Medicaid, the fact that people have an entitlement to nursing home care, yet if they would prefer to receive services in their own homes and communities, states can and do cap access, and we have, as I mentioned, 700,000 people sitting on waiting lists. We're going to hear more from Robert about the direct care workforce crisis, but if we don't have the people to provide the services and supports, that's another barrier to access. And we have 63 million family caregivers who oftentimes have no choice but to step in because their loved one who's aging or has a disability cannot access care. And again, we are in a situation where we need more investment in home and community-based services, but we're in a climate where states are going to be navigating, implementing reductions in Medicaid funding, including through H.R. 1, and we need to really be thinking about how states continue investments in home and community-based services. I want to briefly pivot. While Medicaid is the big player in town, there is a program that unfortunately many people don't know enough about called the Older Americans Act. Unlike Medicaid, that is an entitlement program, the Older Americans Act is funded through regular appropriations. In the small nonprofit world, one would say $2.6 billion sounds like a lot, but it is an incredibly small amount of funding, 2% compared to the amount that goes into home and community-based services through Medicaid. Yet it is incredibly effective. 1 in 6 older adults receive services through the Older Americans Act. And probably many of you are familiar with some of those services. Think about senior nutrition programs, Meals on Wheels. Think about senior centers, transportation, long-term care ombudsmen that protect the rights of people in nursing homes and other facilities. And for people who aren't familiar with the Aging Network, this funding goes from the Administration for Community Living to states through the state units on aging or tribes and tribal elder programs, and then goes to area agencies on aging, or AAAs as they're known, that cover different geographic areas. So everyone has a AAA in their community, and then they contract with a range of service providers, respite providers, Meals on Wheels providers. And if you just look at the data, it is incredible how many people are reached. I always talk about the Older Americans Act as really being the glue, the connector, filling gaps for many people who may not be Medicaid eligible yet because of income and assets, or because they may not be quite at that level of care, people who are receiving care from family caregivers. Incredibly important. We are living in a world where return on investment is critical, and I would make the case that the Older Americans Act is one of our most effective programs. I'll just mention that there has been bipartisan attempts in the last Congress to reauthorize the Older Americans Act. Critically important. Those efforts are continuing in this Congress, and it's going to be really important. I showed you that chart, the huge growth of older adults, yet we've had pretty flat funding for the Older Americans Act, and this is a program that has this return on investment because it keeps people in their homes and out of nursing homes and out of hospitals, and really saves our healthcare system funding. Finally, I'll just end by mentioning, probably people think a lot as you're on the Hill and thinking about engaging with federal agencies about the Centers for Medicare and Medicaid Services, which really does play a critical role in implementing the Medicaid program and working with states. But I just want to mention the important role, at least historically, the Administration for Community Living has played, not only with implementing the Older Americans Act program, but working really in partnership with CMS to bring the perspectives of beneficiaries of older adults, of people with disabilities, and family caregivers. And ACL also plays an important role in funding initiatives around direct care workforce and family caregiving that really advance some of the important goals around home and community living. And with that, I'm going to turn it to my friend Anne.
Thank you. Thank you so much. That was really great. Both Kirsten and Allison set the stage so well. Thank you so much to the Alliance for Health Policy for having me here. And what I want to do is paint a little bit of a picture about the personal financial risk that families incur as a result of long-term care need, long-term service supports need, and then get into some of the solutions that many policy experts have developed over many years that we've now got organized into a compendium that you can access. So I'm going to share a little bit about how we think about organizing those solutions, both at the federal level and the state level. So first of all, Kirsten and Allison have done a great job, I think, of setting the stage around the fact that the population that needs long-term service and supports is one that at any one point in time is living in the community, and particularly even those who have very high levels of need. And I want to stress that when we look in the data and we look at the people who have that HIPAA level of need or that institutional level of need that Kirsten was talking about earlier, we know that actually most of those folks are living in the community. And we also know, and it's not shown here on this slide, we also know that about 60% of the older adults in that population are not receiving Medicaid. They're not on Medicaid. They're not eligible for Medicaid. So we've got a very large portion of this population, very high need, living in the community without access to Medicaid funding. So what do? Well, as you've also heard, they rely very heavily on family caregiving support. There's no question that a very large majority of them rely at any one point in time exclusively on family caregiving. So think about that just for a minute. Imagine having a family member unable to perform 2 or more activities of daily living, and the only support that they're receiving in the home is from an unpaid family member. However, we know that this is a continuum. Certainly there is a lot of functional decline that happens before you get to this institutional level of care need. And even once you are there, there's a process that most families go through in some way, shape, or form that starts with the individual in a home and community, maybe being supported by a family caregiver, and then might migrate to them securing paid supports in the home. And they are paying for those often out of pocket. So we have this entire economy of paid supports in the home from direct care workers that are not covered by Medicaid. And then when that becomes unsustainable for whatever reason, and often in the cases of dementia, that's where we see things like, sort of care needs begin to accelerate even more. Then often there is a placement in a type of care setting called assisted living facilities. They are expensive, but there are a significant portion of the population who are accessing them because they are trying to avoid a nursing home. And certainly they're trying to avoid a Medicaid reimbursed nursing home bed. So think of this as sort of a longitudinal journey that families are on, even though what we tend to do in our work is look at point in time estimates. But yes, for all individuals turning 65 today, our models show that about half of them will get to this very high level of care need, and of those, about a quarter will have it for 5 or more years. So you can imagine the journey that those families are on. And I mention all this just to say that that creates not just a burden, an economic burden on the family in terms of what the family caregiver is giving up in order to provide that care, but also there are a lot of out-of-pocket costs that go along with that. So when we think about what is the problem that we are trying to solve with public policy solutions and the work that has been done over all these years among many experts, the problem that we are trying to solve is twofold. One is obviously we would like to shift the burden for funding long-term care out of Medicaid as much as we can for the folks who get to the part of the journey where they're relying on that program. But also, we would like for families not to have to exhaust their resources to get to that point, or even if they don't ever get to that point, they've still spent quite a bit of money, and it can be very financially devastating. So with that in mind, we have over many years, and I've been involved in this over these many decades, pursued a number of different potential solutions. One of the primary ones that we have pursued has been one where we have said, look, we are just going to create a new program. It's going to be a social insurance program similar to Medicare. Everybody pays in, everybody is covered, and it will essentially move funding. We will replace Medicaid funding with that, or we will replace all of the private out-of-pocket dollars with that. We have also pursued an approach we've seen many proposals to actually, rather than create an entire new social insurance program, to kind of piggyback onto Medicare. Let's create a new benefit in Medicare so that Medicare does cover long-term services and supports. And we'll create it, and it'll be a home care benefit. Think of it as like a Medicare Part E, or it's something we could potentially put in Medicare Part B. But the idea here is that we would tap into, it still would be social insurance, but we would tap into the chassis of the Medicare program in order to not have to create a whole new social insurance program. And so I would say maybe another big category has been to look at solutions to improve the private long-term care insurance marketplace. We don't have enough time to go in here to today why that marketplace hasn't worked as well as we would like, but policymakers have a keen interest in making it work better. And then finally, we've also looked at ways to expand Medicaid to allow for Medicaid to serve as you might call it, the chassis for expanding coverage and third-party payment for some of these services, particularly in the home. And then finally, I think some of the most robust proposals, and the ones that have been worked on over many years with lots of different stakeholders, would actually combine many of these into one. So the idea being maybe private insurance has a role to play, but so does a public social insurance program, and so do state governments. So we can strengthen Medicaid, we can improve the market for private long-term care insurance, and we can have, like for example, a catastrophic social insurance program that would pick up where maybe private insurance leaves off. So we call these the public-private market approaches. And you can find a compendium that explains these in a lot more detail on the UMass Leading Age Center. Let me make sure. Yeah, Center at UMass Boston, Leading Age LTSS Center at UMass Boston's website, where this compendium lives, thanks to the very generous funding support of the SCAN Foundation. So in my very last few seconds, I think it's important to also say another product that is on that website is one where we said to ourselves, okay, so if the federal government, one way to come at this is to say the federal government is going to come up with a big new program. And maybe it'll be partnerships with states or partnerships with the federal government, with private insurance, but we'll drive it. We're going to be the driver. But then we thought to ourselves, what if we kind of flipped that on its head and we said, what if we let states be the driver? Because we know that there are states, many states, that are already doing really innovative things within the context of not just their Medicaid programs, but their programs in general. For example, using state-only funds to extend services beyond Medicaid eligibility, or creating social insurance programs on their own. So are there ways in which the federal government could actually let them drive, but be a partner and be a support to them? And there are a myriad of ways in which the federal government can do that, including very low-lift things from providing technical assistance and stakeholder, support and engagement, all the way to, putting up some more federal dollars to help support the work that they're doing, or allowing for social insurance programs to be better integrated with the Medicaid program. So I'm out of time, but the good news is there are a lot more details on both the federal approaches that we've tried in the past and some of these ways in which we can better support states from a federal perspective, and these compendiums that are on the website. And I'm happy to give you a link if you come see me afterwards. And now I'm going to pass it on to Robert.
Thank you, Anne, and good afternoon, everybody. I also want to start by thanking the Alliance for Health, my fellow speakers, and all of you for the work that you do every day and for attending this conversation today. I will be the anomaly on our panel and I will have no slides for a lot of reasons. But I do want to start by saying that I'm especially aware, as speaking about the direct care workforce, that I'm speaking the day after Labor Day, which was a holiday that was established in the late 1800s to really honor the contributions of workers and set in tone, set in motion a range of ideas and regulations and policies that have supported workers since. I'm speaking specifically about the direct care workforce, and direct care workers, just for level setting, they are home care workers, they are nursing assistants, they are direct support professionals, they are residential care aides working in assisted living environments. They work in private homes and nursing homes and in a wide range of residential care settings. It's estimated that about 70 to 80% of paid hands-on LTSS is delivered by direct care workers. And of course, family caregivers also play a significant part of that work. Direct care workers, according to the latest research, there are more than 5 million direct care workers in this country. They are one of the fastest growing job sectors. They are larger than any other single occupation in the country. And they are so often, for anyone who's ever benefited from a worker, they are critical to a person's health and safety, to their independence, to their employment, to their dignity, and frankly, to the economy through the taxes they pay, through consumer spending, and to the critical roles they play often in reducing emergency department hospitalizations, tracking health problems before they worsen, and so much more. In demographic terms, the vast majority of direct care workers are women, about 67%, 87%, 60% are Black, Latino, and other people of color, and anywhere from 1 in 3 to 1 in 4 are immigrants and or age 55 and older. And that doesn't even include the gray market, where oftentimes people out of financial necessity will hire a home care worker and create their own arrangements, right, often off the books. We often talk, a former colleague of mine used to describe this workforce as the embodiment of the Medicaid economy, because these workers, these jobs are paid for and resourced by an under-resourced Medicaid program, and yet large percentages of direct care workers also rely on Medicaid just to survive, right? So it really challenges the myth that Medicaid supports people who aren't working. The workforce is a great example of that. Among their many tasks, as one of my fellow speakers offered, is really assisting with activities of daily living, instrumental activities as well. They help people bathe, to eat, to dress, mobility. They help with shopping, meal prep, transportation, support. They are problem solvers. They are the eyes and ears of care, and they often embody quite an important role of problem solving with clients and with residents and with family members and the entire care team. Contrary to the gross misperception, even though these jobs are often low wage, it is not low skilled work. It requires significant amount of training so that workers have the skills, the knowledge, and the confidence to succeed in their roles. And when you take into consideration the fact that today's clientele of people they are supporting are becoming not just larger, but increasingly more acute and complex in their conditions, it is in fact incredibly complex work. If we would imagine the ideal from a policymaking standpoint, what would we envision, right? We would envision that direct care workers would have competitive salaries, not just minimum, living wages, but actually salaries with full-time benefits, with quality training that is adult learner centered that they can access at any given point in time, career ladders that allow them to stay in direct care, not necessarily move into the RN or LPN ladder, which is of course, an opportunity that they can pursue as well, or other careers, right? They would have career pathways, I mentioned this. And we would see, for example, that retention would be much higher, that in fact, direct care workers would in fact stay on the jobs. We would talk in policy discussions about their strengths, their enormous values, the possibilities, not just what they lack, even though the current reality is that they lack a fair amount, right? Poverty level wages are the reality for most direct care workers. Limited benefits like health coverage and wraparound supports like transportation and childcare support. Many direct care workers are families as well. Training is scattered, under-resourced, inadequate, and outdated. And oftentimes career pathways are just non-existent. Because of all of this, turnover tends to be anywhere from 50 to 60%, all the way to 100%, and often within the first 90 days of employment. We did a study at PHI a few years ago that looked at all of the COVID displaced workers who were in jobs that were comparable based on wages to direct care workers. And we asked a year after the pandemic started, what percentage of those workers went back into the industry? And across other sectors, it was notable percentages. In statistical terms, nobody in direct care came back after the pandemic. Workers struggle financially, their clients and residents lack the quality care, and employers are left understaffed, and many are increasingly closing their doors, especially in rural areas. We've spoken about the LTSS system realities, and the points that I'll highlight here is that this fragmented state-by-state, under-resourced patchwork that the LTSS system embodies is the same reality for workers. The quality of jobs for workers varies by state to state, from setting to setting. States that spend more on Medicaid have higher paying jobs than those that don't. They are two Americas in many ways. And we are seeing growing demand, both because the population, because we're growing older as a country, people are living longer, higher rates of chronic and serious conditions, of disabilities. And we estimate that between 2022 and 2032, 8.9 million total job vacancies will need to be filled, a percentage of which are new jobs being created, but the vast majority are workers who leave direct care for modestly better paying jobs in fast food and retail. So what do we do as policymakers in broad strokes? We must raise wages and benefits. Again, I argue for a salaried position with guaranteed full-time work and health coverage and careers. We need standardized training that are rooted in core competencies. So if you are trained as a home care worker, you should be able to very easily move into a nursing assistant job without a whole, other range of training and education, and it should be portable from one state to another. So workers have more opportunities, and the workforce is more versatile. And we should have better job quality metrics that measure supportive supervision, adequate staffing ratios, and so much more. I have asked people over the last year, what would our country look like if direct care workers vanished overnight? And it's a grim picture. We can imagine all of that. But I would revert the question and say, what would happen if all the barriers that direct care workers face were to vanish overnight? And that's the question that I hope we can answer today. Thank you.
Well, thank you all. Why don't we go to questions? Just want to start with one, especially in light of Anne's remarks. The panel has gone over the challenges with LTSS delivery and financing. Can you talk more about what different states are doing to address these challenges?
Sure. I'd love to. It falls into some different categories. I would say one category is, in fact, social insurance. So really taking the bull by the horn, so to speak, and creating wholly separate financing streams that will provide payment for services and supports outside of the Medicaid program. That's probably the most dramatic, if you will. We know that a number of states also, maybe on a lesser scale, are pursuing, what I would call a much better portal into navigating long-term service supports. And we didn't really talk about this too much, so that's why I'm hesitating for a minute. just very briefly, family caregivers, family members, and people who have LTSS need are definitely dealing with how am I going to get my need met to, for example, be bathed, to be fed, to be dressed. But there are a myriad of other things that have to be done that is really what you consider to be work that has to be done when somebody has LTSS need. And some of that work is actually looking for it's planning, care, it's navigating the whole infrastructure and system, it's hiring, it's managing, and that in and of itself is a job. And so I mentioned that just to say the number of states have recognized that work and have made some efforts to actually create really innovative portals into resources and helping and supporting family caregivers in finding and managing care. And maybe one other category, though, that I will mention is that as it states, as somebody who's lived in Medicaid for a long time, it blows my mind that states pay for things that don't get Medicaid match, but they do. So a number of states have, in fact, created programs for people who would not otherwise qualify for Medicaid. And there are kind of two ways in which you might not qualify for Medicaid. You might not meet the income and eligibility requirements, or you might not meet the functional requirements. So in order to get access to Medicaid for long-term service supports, you have to have both kind of the financial, you have to meet the financial eligibility, you also have to meet the functional eligibility. And so some states have said, you know what, it kind of makes sense actually to pay for out of state-only funds services and supports that help people maybe before their functioning has declined to the point of being at that institutional level of care, which is where Medicaid picks up. Or it might behoove us to actually address needs before their financial situation gets to that point, because maybe then we can sort of prevent or delay them ending up eventually in the nursing home, which is the most expensive setting of care. So those are just some examples of ways that states have intervened to try to create some. And then there's a lot of private insurance kind of marketplace interventions that they've also attempted.
Thanks, Ann. Another question. The conversation today has really had a lot of focus on Medicaid and less on Medicare. First, why is that? And second, do you see any opportunities to be able to leverage Medicare to ensure access to LTSS?
I'm happy to start, and I'm sure others will add in. I mean, the reason we're at a briefing on LTSS and not talking about Medicare is because Medicare does not cover long-term care. It covers some very short, limited home health, and it covers some short-term nursing home care. And so I think that's a really important point. On the looking forward, I will say we have started some really important conversations, as Ann mentioned, about really thinking about, is that the way it should be? Because we have a Medicare program where the vast majority of people are older adults or people with disabilities, it is a natural place to think about. And there are some ways to build from, there have been bites of thinking about how do we expand the home health, which right now is pretty limited, but that certainly could, if we change some statutory pieces that keep it limited, could really expand. And as Ann mentioned, there have been even presidential candidate proposals to think about how to build some kind of home care benefit in Medicare. So I think you are going to be hearing a lot about this, particularly as we have this huge growing population. But again, I think the message from us to you now is help educate people that they need to be thinking about something other than Medicare right now as they're thinking about their LTSS needs.
Yeah, I think that's great. I think what makes this complicated or a little bit confusing is that when somebody has a need for LTSS, they use a lot of healthcare. So I think in the context, there might be some, it's possible we could see some exciting, we have seen, in fact, an exciting model that's ongoing coming out of the Centers for Medicare and Medicaid Innovation called the GUIDE model, which is an effort to, in fact, put resources in place to help family caregivers and individuals who have dementia manage that care in a way that keeps them out of inpatient hospital settings, emergency rooms, and then ultimately, hopefully, out of a long stay in a nursing home. And I think that's a model that has a lot of promise, and I think we could see, there's certainly the opportunity for the Innovation Center to build on that and to test some models in which we think about the provision of home and community-based services within Medicare as part of a person-centered ecosystem of care delivery that addresses all of those persons' needs and hopefully helps manage them, their care at home as much as possible and avoids the emergency room, avoids the inpatient hospital setting.
And I'm glad you mentioned the family caregiving component, because I think that is something that Medicare is much moving in the direction of, particularly with payment to trained caregivers under Medicare. And so there are some statutory limitations with Medicare in terms of even how it could cover LTSS, but certainly the caregiver piece is a big component that Medicare is currently looking at now.
Great, thank you. Another question is, this is especially for the congressional staffers. If you're approached by a constituent with an LTSS issue, what are some resources to direct your constituent?
Oh, you go.
I'm going to lean in here that, the Administration for Community Living and Older Americans Act does fund resources to help people navigate. You can go to your Aging and Disability Resource Center that's in every state, or your area agency on aging, and actually, I think it still exists. Elder Care Locator was a resource that ACL has long had to help people identify their aging network in their own communities. So the Aging Network is a great resource to at least help you begin to navigate.
And this is where I'm going to plug the Congressional Research Service, because, we have a report that has all the resources that Allison just mentioned, and it's for your constituent work. So check out our website and or contact me, and I can get you access to that.
Great. A couple of questions from the audience. First one, can you talk a little bit more about the difference between what private LTSS insurance offers versus Medicaid? For instance, time or financial limits in private versus need-based in Medicaid? And actually, it's a two-part question. And do people with private coverage or out-of-pocket often end up on Medicaid?
All right, here's my seminar. The design, the kind of traditional design of private long-term care insurance, first of all, it tends to be sold individually, although employers may include it in a package. They don't tend to pay premiums for it, but they will, for example, enable their employees to have access to private long-term care insurance through a broker. The way that private long-term care insurance is designed is it is need-based, actually, in the sense that it is based on functional need, and Kirsten touched on this earlier. So if you purchase a policy, it's let me say this a little bit differently. It's very different than health insurance, and I think that's one of the things. And it's very different than life insurance. It's its own animal, and when you are purchasing it, essentially, you are making a decision at that moment of purchase, which might be 20 or 30 years before you actually need the benefits, as to approximately how much coverage you want to buy. And I'm oversimplifying a little bit here, but it typically is that you will go into that purchasing decision and say, hey, I think I might need about $100 a day for 3 years. And you'll make it, kind of decisions around these parameters of the policy. And then you can access that policy's benefits to pay for a very wide variety of services now. So one of the differences with Medicaid, and one of the reasons why private long-term care insurance can be very nice, is that it usually will pay for assisted living. But you cannot access the benefits of that policy unless you are at the HIPAA level of need that Kirsten mentioned earlier, which is a very high level of need. So I think many people become frustrated because they might move into assisted living or move into independent living and think, why can't I access my insurance right now? And the reason is because you aren't actually at the level of disability necessary for it. And so, there's no, obviously the whole goal is not to spend down your resources, and that's where Medicaid comes in. I think the other question was, are there instances in which somebody might have a private long-term care insurance and then also end up on Medicaid? And the answer is yes. If you buy a 2-year policy and you don't have that many other resources, you go through that policy, you may actually run out of resources. It just depends on, and this is maybe, we talked about this notion of disability as like, half of all older adults will become disabled and 25% of them. If you have early onset, I'm going to just take the most kind of extreme example. If you have early onset dementia, you're 68, you probably will have a very long spell of morbidity. And your family is going to do absolutely everything they can to keep you at home and out of a nursing home. But it becomes very challenging for people with dementia to manage them at home for long periods of time. You might have a long-term care insurance policy that pays for 2 years of care, or maybe you can stretch it out to 3 years, but you might need 10 years. You might be in an institution for 8 years. So the very difficult thing about long-term care, and particularly when people talk about planning for long-term care, that sort of, I bristle a little bit just because it's so very hard to plan. These are needs that you cannot easily predict. And when you buy long-term care insurance, you just do the best you can to buy, what you think will protect your assets and your options, more importantly, for care in other settings besides nursing home care, which is the only one that's actually guaranteed in Medicaid.
Yeah, I will just add, everything Ann talked about. Long-term care insurance is an incredibly complex product to tell people about, to provide education about, to inform people about the decisions they have to make at an early point in their life about their future needs. The market itself is a bit stagnant. There's about 6 million, 7 million policies in force. That's not just of the older population, that's everybody. There are not many people purchasing this product. But where there is potentially some movement here is people are more interested in purchasing these hybrid or combination products, which combine life insurance with long-term care insurance or with an annuity. And so there is some interest there, and for a couple of reasons. One is that you're guaranteed, unfortunately, everybody's going to die, to get something out of this benefit, whether you need the long-term care before you pass away or you get the death benefit or your beneficiaries do that. And so the other part of this is that premiums actually don't increase with a hybrid policy. And that's very attractive to people because what we have seen with the traditional long-term care insurance market is that there have been times when states allow insurers to have a very large premium increase, and some of these times there are 100% premium increases, and that can really drive consumers away from thinking that this is a product that they really want to invest in for the long term. So I think there's some options and potentials to really think about the ways that the federal government can incentivize people to sort of move in this direction of where there's consumer interest in purchasing hybrid products.
Thank you. A question, I think, directed to Robert. How are we recruiting people to join the LTSS workforce?
Ooh, it's a good question, right? So in a few ways. I think one is if you look at the work that employers are doing, and these are home care agencies, nursing homes, assisted living settings, et cetera, what you see in the research and in the online information is a wide range of practices, right? So increasingly more and more people are leaning into new pools of candidates, like underrepresented populations within the workforce, or how do you reach men, for example? How do you reach younger people, Gen Z? How do you reach veterans? And how do you reach family caregivers who are in a critical stage where they're empty nesters, and they might be willing to transfer the skills that they do to bring into that. And you see a wide range of recruitment programs that try to address that. The second is that you do see this more as a public investment question. So because of funding through the American Rescue Plan Act, we did see a number of states develop recruitment approaches that basically used a mix of advertising, framing and messaging, kind of on-air advertising and in the community work, et cetera, just to bring in more people into the workforce and into the candidate pools. It's controversial, but I would also say that AI and technology and digital media is being increasingly used. AI is a way of really segmenting and quickly identifying workers that are available in a specific geographic location. And we saw, for example, a few years ago, a really impressive case study of a marketing agency in rural Minnesota that partnered with an assisted living environment that was struggling to recruit not just direct care workers, but nurses and other frontline staff, right? And so they worked with this digital marketing agency, and they came in with their sophisticated advertising tools. I'm not doing this justice, but they're, understanding audience segments, typographies, all that stuff, right? And they found that most of the workers who were applying were frustrated by how inefficient it was to apply for these jobs when the likelihood of being turned down was low, right? Was high. And so they created a very quick online application process, a quick screener method. They targeted it specifically at men, and I think at first-generation immigrants. And within 3 months, they met all of their recruitment goals. And the big question when you see oftentimes quick hires is, but will you see them a year from now, right? And so they measured retention a year, 2 years later, and they had the same retention figures as they had before. So it was considered a major success. I don't think we see enough in this question about how do you take best practices from the corporate private sector with public need, right? So that we can capitalize on these quite brilliant technologies and approaches that are being, developed, let's say in the marketing world, in the corporate marketing world, to support a public need, right? And so I think some of those are the methods. Yeah.
Great. Here's a follow-up question for you, Robert, from the audience. You brought up creating a career path for direct care workers. Do you have a comparable role or occupation in mind? EMT or pharmacy tech or some other career path?
Yeah, absolutely. I mean, I think that when we think about career advancement in direct care workers, I think there are 3 general trajectories that we can think about, right? One is, how do we create advancement that allows direct care workers to stay as direct care workers, right? Let's say they shouldn't have to leave their role as home care workers or nursing assistants in order to have an elevated title with more compensation, right? And so what you've seen is a growth in roles like dementia specialists, for example, right? People who are then trained in dementia and then play that role specifically. Transition specialists, people who help people returning from the hospital after an acute incident into the community. Senior aides, so these are mentors who help people in the first 30 days of their role, kind of with hands-on support, et cetera. And all of those, if properly resourced and structured, create advancement and allow people to stay within direct care. The second track is into administrative and management positions. And we're seeing more and more employers think about, you're a home care worker, but let's say you want to be a supervisor, or you want to be a manager, or you want to run a nursing home. What are other ways in which you can create those opportunities? And that's kind of a second trajectory. And the third is, I think, what you referenced, which is into other healthcare roles. And that's often requires more extensive training and education. It requires relationships between employers and workforce and community college ecosystem players, right? It's expensive often. It means that you need to be able to support the financial needs of workers who want to pursue that path. But it's something that many workers may want to do, right? And so there's opportunities that go in all three directions. I didn't mention a fourth, which is you may want to go into another industry. We see, for example, direct care workers going into clean energy jobs, right? And that requires a whole different level of training. People skip and move careers in any profession, right? And so why not think about that as well?
Okay, I think we have time for one more question. Can you talk about how behavioral health needs are met through LTSS?
Yeah, I'm happy to start. I mean, as someone who's been in the LTSS space and I've worked across all aging and disability, people often don't think of behavioral health as part of LTSS, and it's incredibly critical that we do. I mean, like other types of LTSS, behavioral health is primarily funded through Medicaid. We often don't think of it in the same HCBS programs because as we think about things like traditional 1915C waivers, you have to meet an institutional level of care, and psychiatric facilities do not count as that institutional level of care, so that's kind of been a barrier. As I mentioned, there have been a lot of different HCBS authorities created over time, and specifically recognizing this issue back with, was 1915 I was DEFRA? In the maybe about 15 or so years ago, there was a new HCBS authority that was created that really helped reach people whose primary issues were mental health diagnoses, and even the new 1915C authority that is in HR 1 that wouldn't require an institutional level of care is something that could help reach behavioral health. And then there are a lot of Medicaid authorities that we consider like state plan, home and community-based services that have been really effective. I'll just mention that there is also a lot of people who both are older adults and have mental health needs. That's been a huge place where actually not just Medicaid, but Medicare has filled in some gaps over the last several years. And for people with intellectual and developmental disabilities, a huge portion of people with IDD also are dually diagnosed. So I think as we're talking about long-term services and supports, it is critical that we think about expanding access across programs, and that people may have both activity of daily living impacts and need supports there, and at the same time also have behavioral health support needs.
Yeah, the only thing I would add is that particularly in older adults, there can be a lot of confusion about underlying conditions and diagnoses. So the challenge is distinguishing a lot of the time. There's big challenges distinguishing between true, psychiatric diagnoses and dementia. Those two things, and Parkinson's, other neurological conditions. There's a lot of, and I'm not a clinician, but so I'm like way out over my skis. But what we see, and when we talk to family caregivers, is that there's a lot of frustration in getting the appropriate medical care and long-term service supports relative to that person's needs because of the challenge of disentangling what's really kind of the root cause of what's going on with that individual. And then, of course, for a lot of neurological conditions, dementia and Parkinson's, there can be new behaviors that have to be managed. So long-term service supports can also be about managing behaviors that are new and kind of a product of the brain disease. So it's a very complicated, intricately connected set of issues.
Yeah, I will just add, one of the policy sort of issues, particularly in the Medicaid program when it comes to individuals with behavioral health diagnoses, is that the ADL or the institutional level of care criteria may be a very high, if not impossible, threshold. Mm-hmm. I mean, when somebody has a behavioral health challenge that maybe is very acute, they may have limitations with the they may have limitations with their ADLs or activities, but that might change if they're in a medication management situation or some kind of in-person treatment. So, when I think of policy, particularly in Medicaid around this population, it's the umbrella of the home and community-based services, because those are often the types of services that people with behavioral health are primarily focused on and needing. And then, whether there's an LTSS need or it meets that institutional level care is kind of a separate policy challenge, can also be a barrier here in the Medicaid program. So I'm glad Allison mentioned there is a change in that was part of HR 1 to add under the Section 1915C Home and Community-Based Waiver Program the ability for states to offer a package of HCBS to people with lower level of care need. Mm-hmm. So I think it'll be really interesting to see what states do with that in the future.
If I can also add, this is a major responsibility for many direct care workers. They often are assessing for agitation, for escalation. They are stepping in not just with clients dealing with behavioral health issues, but also with family members and with broader environments. And it is often a major training and a competency within training programs. One possibility here is technology. There are an increasing number of tech tools that are being developed, hopefully more and more evaluated, that can detect levels of agitation, escalation, et cetera, and then use predictive analytics to assess when somebody might be going into a place that requires a much more serious intervention, and then transmit that information to a person's care team, their family members, et cetera. Of course, that needs the right the proper privacy safeguards and a range of other issues. But if we can think about technology as a complement to the work that a lot of us need, I think there's possibility there.
Well, I think that's it for time. Many thanks for our panelists. Please join me in a round of applause.
Wonderful. Thanks so much to all our panelists. I will say also thanks to the audience for so many great questions. You typically when we do these events, people have kind of a lot of the same question. It was a real diverse set of questions. People had a lot of really interesting questions. So we could go on and on, but unfortunately we do only have the room for a limited time. So I just want to say a couple of thank yous in addition to thanking our esteemed panel. I want to thank our sponsors again for their commitment to this work, which we continue to think is very important and are so glad that they are committed as well. I want to remind you, if you don't see the QR code in my earlier slide and also at your table, definitely share this report out with others, particularly those who are trying to raise awareness about aging policy and how important it is. I want to invite all of you to our upcoming Health Policy Forecast event, which is Tuesday, November 18th at the Barbara Jordan Conference Center. And we'll also have an evening reception at Astro Beer Hall, which does include donuts and beer. So we heard the aging community, likes to have a good time, and there will also be games. So we'd love to see you all there. What's coming up next for us, because the Alliance never rests, we talk about aging this year. Next year, we're going to talk about a small topic of some interest to some people called healthcare payment. So just the same way I shared that we did the ongoing program with many different events and different educational opportunities, we will be doing that on that topic. And when, if you want to stay informed on the topic of healthcare payment, go ahead and snatch that QR code right now, and we will make sure that you have the ability to sign up for more information. Finally, we are a learning and listening organization. Please let us know what you thought of today's event and how we could meet your needs better next time, or anything we did well that you enjoyed. Go ahead and share with that through our survey. So thank all of you for coming, for spending your time with us, for giving us great questions, for doing the U at 80 exercise. I hope that gave you something to think about. And we'll hope to see you at the next one.